Hello and welcome to Long COVID Foundation podcast. This is the channel where we share education and information on long COVID to help you understand your symptoms better. In just a moment, we'll have an interview with Dr. Galland on MCAS in long COVID, where we will cover what it is, diagnostics, symptoms, and treatment options. We had numerous questions from our Facebook group members on this topic. If you are new to this group, please follow the link below. I would advise to watch this video from start to finish because it will help you to learn more. If you are new to the channel, make sure you hit subscribe button because I can help you to get answers relevant to your symptoms. An important disclaimer, what you will hear tonight is not personal medical treatment. Take this information back to your physician and seek medical advice which best suits you. It is also important to mention who we are. We are a UK registered charity offering education and information. We only came together for the purposes to share information on long COVID and raise awareness about this debilitating syndrome. We depend on your donation, and we thank you to many of you who donated for helping us to spread the message. Thank you very much, and let's jump straight into our interview. Hello and welcome to Long COVID Foundation channel. It's my pleasure to welcome Dr. Galland, our medical board advisor, recognized world leader in functional and integrative medicine, author of numerous books on diet, allergy, indigestion problems, regularly chosen by New York Magazine as one of the best doctors in New York. Dr. Galland, thank you very much for being with us today. It's such an honor to have you again on our channel.
It's always a pleasure to speak with you, Valentina.
Today we have another challenging topic to discuss, never easy, which is MCAS in long COVID. Many of our listeners raised questions on how it can be diagnosed, treated, especially during long COVID. So I would love to hear your perspective on this subject as to help us learn more.
Mast cell activation syndrome, or MCAS, is a very complex, somewhat controversial disorder. I think it's important to put it in context, and because there is a lot of research that is ongoing into the causes of long COVID and the many factors that contribute to it, and each piece of research sort of is presented as if, oh, here's the cause of long COVID. And maybe there's a treatment, maybe there isn't, but it's as if everything is just out there, unconnected to everything else, which is why I created a schematic, a diagram called the web of long COVID. If you can just put that up there. And what I find is that the research that keeps appearing reinforces the components of this web. And I think it's necessary to understand the whole web, not just one strand, especially if you're struggling with long COVID. At the center is a condition called ACE2 deficit. ACE2 is the vital enzyme that the virus uses to attach to cells. It's damaged when the virus enters your cells. And the effects of that damage are multiple, including all of the things that I'm going to be addressing in a moment. One of the impacts of that is stress to the mitochondria, the powerhouses that that supply energy for your cells. Now, out of that come several strands. Going up towards 12 o'clock is inflammation of the lining of blood vessels, endothelitis, which I think is really critical to the development of COVID and non-COVID. Related to that, at about 1 or 2 o'clock, are microclots forming in blood vessels. I have mast cell activation going out to 3. And each of these strands is connected to one another by other strands, because mast cell activation can contribute to microclots. Down around the bottom of the web are other types of immune imbalance. And some of these may actually be the result of, or may help to create, the state of mast cell activation. And then going around to 9 is persistence of the virus or other viruses that become reactivated. And that may actually reflect the immune imbalances that occur. And then there's some gut dysbiosis, microbial dysbiosis, which I spoke about the last time we were together. So I would like everyone to keep this web in mind as I talk about mast cell activation, which in my experience is a key component, especially for those people who get stuck, who don't respond the way that we'd expect to the treatments that are being offered. Okay, so mast cells are very primitive cells of the immune system. They're large cells that are sparsely scattered around the tissues of the body and are not seen circulating in blood. Most of the immune cells that are active you can see in blood, but mast cells are really in tissues. They contain granules that store up to 200 different chemicals that are called mast cell mediators. And when mast cells become activated, they may migrate and move around, and they release these mediators through something called degranulation. The granules open up, the mediators are released into the local environment, where they can kill certain microbes, but they also create a great deal of inflammation. Now, mast cell activation is a key component of many infectious and inflammatory disorders and allergies as well. It may not be the primary event, it may be a secondary event, but it definitely plays a role in the inflammation that occurs. And mast cell activation is very common during the acute phase of COVID-19. Mast cell mediators may be activated and released in allergic conditions, and allergic antibodies, the so-called IgE or immunoglobulin E antibodies that are part of classic allergy, find a receptor on the surface of mast cells. And the cascade of events that creates an allergic reaction, mast cell mediators are the payload at the end, releasing, creating all of these effects of allergy. Now, in order for a mediator to cause symptoms, and I think this is important to understand when we get to therapy, it must first react with a receptor that is specific for that mediator on a target cell. And most mediators have more than one kind of receptor. So the actions of each mediator may vary depending upon which type of receptor it activates. The next cell, please. So histamine is the most famous and best known of the mast cell mediators. And mast cells are a leading source of histamine in the body. Histamine typically causes the symptoms of acute allergies like hay fever or hives by activating a receptor called the H1 receptor. H1 receptor activation dilates blood vessels, producing redness and heat, and makes them leaky so that blood plasma seeps out from the blood vessels into the surrounding tissues, causing swelling. H1 activation causes many of the symptoms associated with classic allergy, sneezing and hives. And standard antihistamine drugs block the H1 receptor. That's their function. Now, the H2 receptor also makes blood vessels dilate, but the H2 receptors are best known for increasing the secretion of stomach acid. And drugs that are H2 blockers are mostly used to reduce stomach acid, but they can have anti-allergic effects that are additive with those of the H1 antihistamines. And an important fact about histamine, which is not well known, is that histamine suppresses T lymphocyte function through both the H1 and H2 receptors, so that high levels of histamine can be associated with immune suppression. This becomes important when we think about the effects of immune suppression in viral illness. Now, the other best known mast cell mediators, serotonin. Serotonin is mostly known as a neurotransmitter in the brain. It causes constriction of blood vessels, the opposite of histamine. It increases motility and movement in the GI tract, so it may cause diarrhea, abdominal pain, cramps. In the brain, serotonin has numerous effects on mood, sleep, and cognitive function. Prostaglandin D2. Now, the prostaglandins are mostly known for their role in pain. And the drugs that are most used for treating pain, the so-called non-steroidal anti-inflammatory drugs and aspirin, work by blocking prostaglandin synthesis. Mast cells release a particular characteristic prostaglandin called prostaglandin D2. Now, that can cause asthma and constriction of bronchial tubes, and it plays a key role in wheezing. It dilates blood vessels and can cause flushing of the skin. It slows hair growth and may induce sleep. Heparin is best known as an anticoagulant. It's released by mast cells when they're activated. Its exact function isn't known, but it may systemically activate a system of inflammation and blood clotting that actually produces the opposite of what we use heparin for. Norepinephrine or noradrenaline is a neurotransmitter that is key to the activity of the sympathetic nervous system. That can be released by mast cells. Now, that can cause constriction of blood vessels, but it may raise blood pressure. It can speed up the heart rate. And symptoms such as POTS or just rapid heart rate may be the result of mast cell activation through the effect of norepinephrine. There are other mediators in the family similar to prostaglandins. They're derived from fats, dietary fatty acids. They're called leukotrienes and thromboxanes. They play a role in allergic reactivity, wheezing, blood clotting. And then there are a whole group of cytokines that have various kinds of inflammatory and fibrotic effects. VEGF, or vascular endothelial growth factor, is an important one. TNF alpha is important for inflammation and has received a lot of attention, along with interleukin 6 in the setting of acute COVID-19, and interleukin 13, which I find to be very important for some people with long COVID. And many of these can be measured in blood. There's been research into the mast cell activation syndrome for a few years. The background is most of the early mast cell research dealt with a condition of tumors of mast cells, basically something called mastocytosis, in which there was an excess in the number of mast cells. And most research on mast cells still deals with that. But it's become clear that there are people who do not have excessive numbers of mast cells. They just have mast cells that are hyperactive and respond to many different stimuli in a way that is not normal. And this phenomenon is thought to be related to genetics. The leading theory is that mast cell activation occurs in people who have inherited genes that produce hyperactive mast cells. And those might respond to minor innocuous triggers. And it may be, I certainly over the years have seen a lot of people with post-infectious mast cell activation syndrome. I think that does occur with COVID-19, and it may be that there's a genetic susceptibility to this happening, so it won't happen in everybody. A family history of allergy or multiple sensitivities would be expected in people suffering from genetic predisposition to mast cell activation syndrome. And several studies have indicated that probably the greatest risk factor for developing long COVID is a history of asthma. In people with a history of asthma, the incidence of long COVID is 5 to 10 times as great as in other people. And that may reflect a role for mast cell activation or a predisposition to it, because mast cells are important for asthma. Now, the common symptoms associated with mast cell activation include fatigue and multiple sensitivities, allergies or pseudo-allergies, also skin rashes, itching, wheezing, coughing, feelings of being cold or occasionally of being hot, often accompanied by sweats. Swelling and weight gain are common, but fluctuations in weight or unexplained weight loss may occur. And intermittent gastrointestinal symptoms, especially pain and diarrhea, are pretty common. Mast cell activation may raise or lower blood pressure. It may cause blood clots, and it does that in part by activating the blood platelets that initiate clot formation. And mast cells play an important role in migraines. And many of the phenomena associated with long COVID, especially the neurological phenomena, have the flavor of migraine, even if the headache component is not very strong. Now, in the web of long COVID, if you can keep that diagram in mind, mast cell activation may contribute to microclots and to endothelitis, the inflammation of the lining of blood vessels. It may also contribute to the T lymphocyte dysfunction that has been described in people with long COVID, especially with neurologic symptoms. And each of these things may occur independently of mast cell activation, but they may be increased by mast cell activation. That's why I see this as a web with every strand connected in some way to every other strand. There's not, for many people, there's not a single route out of it. You have to deal with all of the strands that are relevant for that person. There are all sorts of things that may trigger mast cell activation, especially when one is in this state of having the activation syndrome. So I tend to suspect it in people who have adverse or paradoxical reactions to multiple medications, supplements, or environmental triggers. I mean, if I'm seeing a patient who initially I don't think has mast cell activation, they have a defined set of problems that we're working with, but 70% of what I recommend is not tolerated by that person. Even though it seems as if this should address their problem, I will definitely start thinking about mast cell activation. There are also a wide range of environmental triggers that can create symptoms. Drugs and insect stings and allergens, just physical pressure, changes in temperature, sunlight, any new environmental exposure may provoke symptoms. And so one of the things that I ask when people are symptomatic is I look for changes in the environment or diet that were associated with the onset of these symptoms in time, and then try to figure out if that's a real association or a coincidence. And as I've said before, the long haulers who are most likely to have mast cell activation, in my experience, are those who have not responded as expected to attempts at treatment or symptom relief. Okay, so these are charts of the common symptoms, and they may occur in any organ because mast cells are found throughout the body and they release so many different chemical mediators with such a wide range of effects. And, fatigue, malaise, sweats, weight gain, lightheadedness, dizziness, weakness, decreased libido, skin rashes, itching, flushing, swelling, dryness of the skin, poor healing, sores, hair loss, striae, streaks on the skin, irritation of the eyes and redness and dryness, trouble with focus, twitching of the eyelids. And different mediators may create different effects. Changes in hearing, ringing in the ears, throat irritation or itching. And itching is, because of its association with histamine, is really very central kind of symptom. Burning mouth, mouth sores, swelling of the tongue, lips, gums, cheeks, postnasal drip, having to clear your throat is pretty common. Enlarged lymph nodes may occur and they may be tender to the touch. And certainly nasal or sinus congestion, nosebleeds, coughing, wheezing, trouble taking a deep breath, abdominal pain, bloating, diarrhea, even constipation, heartburn, discomfort with urination, back pain or side pain, migrating pains or diffuse pains in the soft tissues of the body, nervousness, headaches, numbness, tingling, tics, tremors, anxiety, depression, memory problems. And some of these are due to the changes in blood flow in the brain that result from mast cell activation, increased susceptibility to true allergic reactions and to infections, and slow healing of infections. There's been some data suggesting that mast cell activation is actually associated with increased susceptibility to fungal infection. And as I discussed in the microbiome interview, increase in fungal infection is one characteristic of COVID-19. Palpitations, rapid heart rate, fluctuating blood pressures, chest discomfort, abnormal blood clotting or bleeding, those are all possible symptoms. So we're covering the whole range of symptoms, except maybe for loss of smell and taste that have been described in long COVID. Now, there are a number of disorders that historically have been associated with mast cell activation by different researchers: fibromyalgia, chronic fatigue syndrome, vulvar vestibulitis, a pain syndrome, interstitial cystitis of the bladder, endometriosis. Kids with autistic spectrum disorder have shown evidence of mast cell activation. There's a role for mast cells in osteoporosis, hypothyroidism, malabsorption of nutrients, POTS, postural orthostatic tachycardia syndrome, a common complication of neurological COVID, is associated with mast cell activation. And from a genetic perspective, there is a condition called Ehlers-Danlos syndrome. It is genetic. It involves hyperflexibility and distensibility of joints and sometimes skin. Doctors who work with this condition have found mast cell activation and POTS to be associated with it. And in many of the patients that I've seen who've had a post-infectious mast cell activation syndrome, hyperdistensibility has been present. So I think that is part of the genetic background. You can test yourself for it, for hyperdistensibility of the joints. I mean, I don't have it, but if you can move your finger back more, your fingers way more than I can move mine, if you're prone to injure yourself with physical activity, it's something to look into. And there are specific treatment approaches there. And the researchers who explore these areas believe that chronic release of mast cell mediators contribute to the formation of each of these disorders. There are blood tests that are done to make the diagnosis of mast cell activation. Frankly, false negative results are very common. And I think all of the doctors who deal with mast cell syndromes recognize this. There may be abnormal blood cell counts, especially an elevation of cells called monocytes. or sometimes eosinophiles, which are attracted to sites of mast cell activation. Elevated liver or muscle enzymes may occur, but that's not very specific. Low or high iron levels measured as ferritin, that's also not specific. Low magnesium and low copper have been described. And the copper is interesting because low copper is an unusual laboratory finding. Copper is an essential cofactor for detoxifying histamine. The enzyme diamine oxidase that breaks down histamine is a copper-dependent enzyme. And so low copper may really be important in this setting. There's an enzyme called tryptase, which is quite specific for mast cells. If tryptase in blood is elevated, that's a pretty sure sign of mast cell activation. Chromogranin is another mast cell mediator. And if that's elevated, that may be a sign, although you get false elevations if you're taking acid suppressing drugs. Plasma histamine is the most common in my experience, but the blood has to be handled properly. It needs to be frozen quickly. If it sits around, the histamine will break down. Plasma or urine prostaglandin E2 or leukotriene E4 would be signs of mast cell activation. But at the end of the day, the diagnosis is based on a multiplex of symptoms and response to treatment. Even if all the laboratory parameters are normal, mast cell activation may still be present. So the treatment is challenging to begin with. In fact, it's just as challenging as the diagnosis. And the challenge lies in the fact there is no perfect drug. Often multiple treatments are needed. And people who have mast cell activation are prone to have adverse reactions, even to those things that science would tell us, oh, this should help that person. This should stabilize mast cells. This should block the action of mediators. You can have adverse reactions. Sometimes it's to the drug itself. Sometimes it's to the excipients and inactive ingredients that are being administered. Now, most of the treatments are focused on the mast cell mediators, and their purpose is to inhibit the production of mediators. It's not so easy. Inhibit the release of mediators through what's called mast cell stabilization. There are just a few things that do that. More commonly, to block the actions of the mediators that are released, or maybe to hasten the breakdown of released mediators. And these same principles apply whether we're using drugs or whether we're using natural products. It may take a month of daily use of these treatments to determine the potential benefit. And the duration over which they need to be continued is uncertain. And as I said before, there's not one magic bullet. Multiple treatments are usually needed. There are a number of things you can do yourself if you suspect that mast cell activation is a key component of long COVID, or if your doctor has said, we think you have mast cell activation. First of all, there are over-the-counter medications widely available in many countries. Aspirin, ibuprofen, and non-steroidal anti-inflammatory drugs, the NSAIDs, block the synthesis of prostaglandins. They inhibit synthesis of prostaglandin D2 and may be helpful. Now, none of these are without problems. That is because there's abnormal blood clotting in long COVID. Aspirin is preferred over ibuprofen and naproxen and the other NSAIDs. However, there are a lot of side effects with high dose aspirin. Typically, I use aspirin at a dose of 1 adult strength aspirin a day, 325 milligrams, rather than pushing it high to try and just get pain relief. Standard antihistamines, the H1 blockers, can be very helpful. And there actually have been some case reports that have appeared recently of people with long COVID who were given antihistamines for some other reason and found that their long COVID symptoms really improved dramatically. Loratadine, desloratadine, cetirizine, fexofenazine, diphenhydramine, those are the generic names of those. They're generally well tolerated. Sometimes you need a very high dose, 2, 3, or even 4 times the standard dose to get benefit. And as you start pushing the dose up, the risk of side effects increases. The H2 blockers have been used a lot in the treatment of COVID. Ranitidine is off the market, at least in the US, because of contamination. Famotidine is the most common and has been studied in acute COVID and a little bit in long COVID. The standard over-the-counter dose is about 10 milligrams. The dose used in treating acute COVID, there has been a range of 80 to 240 milligrams. There was a study that was done in people with long COVID that gave them 5 milligrams of loratadine and 80 milligrams of famotidine. And after about a month, there was not only an improvement in the symptoms of long COVID, there was an improvement in T cell function. So these were not just working to relieve symptoms as antihistamines, but actually by blocking histamine, acting as immune modulators. Now, I very frequently use that combination. I'm not overwhelmed by how successful it is because I think the process is very complicated, but it's definitely worth exploring this. Now, there are some drugs that are mast cell stabilizers, and they are available over the counter as topical preparations, eye drops and nasal sprays. Ketotifen and cromolyn are the commonest. Compounding pharmacies can make cromolyn, you can get cromolyn by prescription. It only works in the GI tract because it's not well absorbed, but it may be helpful when there are GI symptoms or reactions to food. Ketotifen in the US needs to be made by a compounding pharmacy. There's some other prescription drugs that may be helpful. Hydroxyzine, which is an antihistamine and a mast cell stabilizer. Main side effect of that is it's very sedating. Cyproheptadine is a serotonin antagonist used to treat childhood migraine and may have some value. Then there are the leukotriene antagonists that are most commonly used for asthma, montelukast and zafirlukast, and steroids. Prednisone, dexamethasone, and other adrenal steroids may be helpful with mast cell activation. From my perspective, they're a last choice with long COVID because of their immune suppressing activity. Now, there are many nutritional treatments that can be explored. And there are many substances that have been found to be antihistamines or mast cell stabilizers in laboratory studies. Many of these have been tested in clinical trials, although there are no studies on long COVID as yet. At the best known and at the top of the list is quercetin, a bioflavonoid that's found in many foods. And high doses of quercetin, we're talking about 2,000 milligrams a day, has been shown to block an allergic contact reaction to nickel, contact dermatitis. And that requires the downregulation of mast cells. Now, and I use quercetin quite a bit in patients with acute COVID and with mast cell problems. The one caveat that I have about quercetin is there is a single study from the University of South Florida that showed that quercetin inhibits ACE2, and a deficit of ACE2 plays a role in the complications of COVID and long COVID. So I think, if I encounter a patient who's been using quercetin, I will see whether they do better without it. But and when I introduce it, I want to introduce quercetin as the only treatment and make sure there's no adverse reaction. Now, this study used a single dose of quercetin and its metabolites in a test tube And it's possible that with regular daily use, that effect goes away, because many of the effects of quercetin are consistent with the anti-inflammatory actions of ACE2 rather than inhibition of ACE2. Pycnogenol is another bioflavonoid, an extract of the bark of the French maritime pine, and that prevents mast cell activation and histamine release. The doses used there are generally 100 to 200 milligrams a day. That's a patented product. All pycnogenols are the same, whereas quercetin comes in many different forms, and its bioavailability may be very low, which is why in the study with nickel contact dermatitis, they pushed the dose to 2,000 milligrams a day. Luteolin is another bioflavonoid. It's found in parsley, celery, numerous herbs. It's found in perilla leaves, which are an herbal remedy in Japan. And it has anti-inflammatory and mast cell inhibiting effects. Luteolin may also inactivate some of the mast cell mediators. Now, to be really well absorbed, luteolin needs to be in a liposomal form. It also has limited bioavailability like quercetin. And doses needed in a liposomal form, and that is available, are in the range of 150 to 300 milligrams a day. Olive leaf also has mast cell stabilizers, especially a water-soluble substance called hydroxytyrosol and oleoeuropine. These are available as supplements in many countries, either just as olive leaf extract or the hydroxytyrosol or the oleoeuropine itself. The oleoeuropine has some antimicrobial effects. The hydroxytyrosol is a potent antioxidant. Fisetin is another bioflavonoid. It's found in numerous fruits and vegetables. It is most concentrated in strawberries. And a cup of strawberries will provide a clinically significant amount of fisetin. Thymoquinone is a polyphenol that is found in black cumin seed, Nigella sativa or Nigella indica, in the oil. And those are widely used throughout Asia and North Africa for their anti-inflammatory effects. And there are supplements containing thymoquinone that may be helpful. Thymoquinone may be antiviral as well. And it has a number of very interesting anti-inflammatory effects. There is a peptide. Peptides are strings of amino acids. There's a peptide called BPC157. Most of the initial research on this was done in Croatia, but it's available in a number of countries. It is a synthetic form of a substance naturally made in the stomach. It can be taken by injection or orally. And BPC157 is a mast cell stabilizer. It also helps with heartburn and acid reflux. Injectable peptides may be helpful. Thymosin alpha-1 and thymosin beta-4. You'll need a doctor who does peptide therapy for those. Melatonin stabilizes mast cells, and it's something that's very commonly used in the setting of COVID-19. And there's also a traditional Chinese formula from traditional Chinese medicine called Shuang Huan Liang. If you can find that, that's been helpful for some of my patients with mast cell activation. And diet may have an effect. There are two directions to go in terms of diet. Some people with mast cell activation are very sensitive to histamine, and a histamine-restricted diet may be helpful. And you can find information on that online, the foods to avoid, in order to restrict the precursor amino acid of histamine, which is called histidine, or components of food that cause histamine release or that interfere with the breakdown of histamine in the GI tract or in the body. And there are also gut microbes that may release histamine, and there are others that may break down histamine. So if you suspect that mast cell activation is a component of your problems, it may be worthwhile. This is something you can do on your own. You don't need a doctor for this most of the time. Exploring the role of dietary histamine in creating your symptoms. And aside from avoiding the major offending triggers, may be worthwhile incorporating natural mast cell stabilizers as foods as well as supplements. Olives, strawberries, and parsley. Celery juice may also be helpful. Just remember that anyone with a mast cell or histamine problem might have the opposite effect of what we're looking for from a treatment that should help. Those are a set of guidelines that you can mostly follow on your own, because it's going to be hard to find doctors who are experienced in dealing with mast cell activation, that hopefully can help you identify whether mast cell activation is part of your long COVID problem or and contributing to the symptoms that you have, and give yourself some relief. And in addition to symptom relief, dealing with mast cell activation can help with blood clotting, inflammation of blood vessels, and the immune suppression, the imbalances creating impaired T lymphocyte function that have been demonstrated as occurring in people with long COVID.
Thank you very much for this very informative presentation. And I would definitely agree that it is hard to find a doctor who would be specialized in properly identifying mast cell activation and then properly associating symptoms to mast cell activation. And before planning this interview, within the group, we had a discussion on mast cell activation, because all these symptoms that you have covered are hardly associated with mast cell activation. Some of our members raised some questions to you, if you would be happy to answer them. One of them is how to separate MCAS reaction and dysautonomia if you have both of them.
Okay, yeah, that's a very good question, and it's very tricky, especially because of the association of POTS with MCAS, and to some extent it will be related to circumstances and treatment response. And nobody is a big fan of try this and see if it helps. But that often is the only choice. And my goal with everything that I put together on long COVID is to try to be really systematic. And okay, we're going to explore this, we're going to try this, we're going to see what happens, then we're going to move on to the next area if we need to. So the standard way to assess dysautonomia is with a tilt table test. You can do your own version of this by checking your pulse and blood pressure after you've been lying down for about 5 minutes, so everything's stable, and then standing up and leaning against a wall, so your muscles are not constricted, they're relaxed. You're standing, leaning against a wall, and you check your blood pressure every minute for 10 minutes, and your pulse, and you see what the changes are. And in a video that I posted on YouTube called Healing Long COVID, I have a description of that and how to interpret it, and also a link to a website in the US that has information about that. That is kind of the basic way to try and establish dysautonomia. With mast cell activation, there will usually be other symptoms. It won't just be the dizziness and weakness. And what causes that, because what is causing the change will be the mast cell mediators. So there may be changes in skin color, for example. There also will very likely be a different set of triggers, maybe the kinds of things that activate mast cells, or it may follow food or taking a particular supplement.
Thank you. And the last question I will take from our listeners is, if tryptase is negative, can you still have MCAS? And followed by low histamine diet. Is it required to have it for the rest of our lives? And to support this, the person has got symptoms of itching, flushing, shortness of breath, mucus and throat, head pressure, chronic fatigue, visual disturbance, heart palpitations, heart rate, which is high, and brain fog. So it's a whole range of symptoms that you have covered, I think, to support MCAS.
Okay. A normal tryptase can occur with MCAS. And in fact, if the tryptase is high and persistently elevated, most likely the person has a low-level mastocytosis. Tryptase has a very short half-life in the body, so unless you grab it while it's still there, it's easy to miss it. Yeah, I've seen lots of patients with normal tryptase who have mast cell activation, and some of them have high histamine or high prostaglandin D2 and respond to the treatments for mast cell activation. Now, if you benefit, the first question with a low histamine diet is, does it help you? And if it helps you, that's great. Are there things that, are you stuck with it for life? Not necessarily. The histamine intolerance may be impacted, first of all, by copper. So it's really worthwhile checking the levels of the enzyme that breaks down histamine, called diamine oxidase, or DAO. There are some labs in some countries that will measure that. Looking at your genetics to see if that's available to you, what the gene that creates DAO, do you have one of the polymorphisms of that gene associated with lower activity? You can take DAO as a supplement with meals. That may expand your ability to eat foods that you couldn't eat without the DAO. Correcting copper deficiency can be helpful. And as I mentioned, gut microbes can have a pretty significant effect on histamine in the gut. Some break down histamine, others release it. And there are some supplements of certain specific strains of lactobacilli and bifidobacteria that may help. So altering the gut microbiome may decrease your histamine intolerance. And then there are foods and supplements that naturally block histamine. One of the big problems with the low histamine diet is it's not really a very healthy diet. And so it becomes possible to develop some micronutrient deficiencies, which aggravate the problem. So trying to make sure that your diet really is nutritionally adequate and healthy, it is possible to reverse histamine intolerance, is the bottom line.
Thank you so much for this answers. I'm sure our listeners will appreciate it. Give us a like, share this information among your medical practitioners, help us raise awareness about long COVID and its impact on people's well-being. I will stop it here. Thank you for watching, and goodbye.